And I will wait for introductions.
Welcome everyone to the July 30th, 2020 COVID-19 clinical rounds focused on emergency department, patient care, and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 emergency department challenges and successes. If my emergency department is preparing for or experiencing a surge in COVID-19 patients, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration. Thank you to the multiple professional organizations who have collaborated among multiple disciplines. These are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to our team at Project ECHO, Dr. Bruce Strumminger, Amanda Dizan, Amy Amistad, and others at ECHO for their support and the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Next Monday, August 3rd, will be EMS rounds with a focus on EMS education. Next Tuesday, August 4th, will be critical care rounds, but please note that those critical care rounds will be on transitions of care from acute care to long-term care, with speakers, panelists, and participants being invited from both acute care and the long-term care communities. Stay tuned for announcements for future rounds. It is self-evident that our nation's medical response challenges continue to change daily. We'll continue to work to identify topics for these peer-to-peer learning rounds that are most timely and helpful to clinicians. Importantly, many of our prior speakers, panelists, and participants have been through a first wave and have much to share and help those now facing or about to face a surge of COVID patients. For these ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly physicians, nurses, and EMS clinicians. I do want to note, in terms of the multiple countries that do participate, we're grateful for our colleagues who participate almost on every one of these rounds from St. Kitts and Nevis. Thanks to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. Thanks to the American College of Emergency Physicians and the Emergency Nurses Association and the recently joined American Academy of Emergency Nurse Practitioners and their support of these emergency department focused rounds. We apologize in advance. We're not able to answer all the questions we receive in advance of the rounds. We do select major themes and hope to cover some of those. I'll now turn this over to Dr. Bruce Strumminger from Project ECHO.
Thank you, Rick, and welcome to Ed Michelson, our guest presenter today, and to our usual expert panelists, and in particular to all our participants who are so faithful and coming back each week. Just gonna share a few housekeeping items. Remind everyone there's a Q&A function, a little button in the bottom Zoom toolbar. We really welcome your questions and comments. We'll be looking there to track those and try to answer as many as we can. There's a chat function as well in that toolbar. If you've got technical or logistic issues, please bring those up there. We'll try to address those as best we can. Also, Rick will be asking a crowdsourcing question, and the chat function is the place to put your response. This session is being recorded and your attendance is consent to be recorded. Thank you. The presentations for today are, or the presentation is linked to the most recent email announcement that came out from Project Echo. It will also be available on our website as well as the recording. We'll be sharing a link to that in the chat later in the session, and the links to that will be in subsequent emails. There will be CME and continuing professional development credits available through the University of New Mexico, where Project Echo is based. We'll put a link about 15 minutes before the end of the session in the chat. Also, there should be a link in the announcement that went out this morning. These learning sessions are focused on improving patient care in health systems and supporting clinicians. Just a reminder, we want to keep the conversation apolitical. Thank you all for that. And a word about data use. When you registered, the polling responses, what you put in the chat, the questions, it's all data. Just want to ensure everyone that we keep that data confidential. We do share the de-identified data with Rick and ASPR, and they review that regularly to inform the national response to COVID-19. So thank you for sharing your ideas and your information. Now I want to hand it over to Sharon Van Aersdale with NETEC at Emory to talk a bit about the webinar series.
Thank you so much, Bruce. Hello, good morning, good afternoon, everybody, and happy Thursday. My name is Sharon Van Aersdale. I am the Program Director for Emory's Serious Communicable Diseases Unit. By background, I'm an emergency department nurse. I'm also the Director of Education and Resources for the National Emerging Special Pathogen Training and Education Center. And it's been a privilege and an honor to be able to participate in these clinical rounds representing NETEC. Really allows us to better understand what your needs are. So if there are things that you want to hear more about, putting it in the chat, asking these questions allows us to kind of better understand and do a deep dive on those. So definitely check us out at netec.org for additional information.
Great, thank you, Sharon. AAMC is a partner in this clinical round series. Dr. Rosha McCoy often joins us to highlight the AAMC Clinical Guidance Repository. She wasn't able to join today, so we just want to remind everyone that this is a wonderful resource. It's updated weekly and has a treasure trove of guidance for COVID-19, and we encourage you to check that out. Also want to give a brief marketing plug for the Health and Human Services telemedicine series that launched last week. The second session was yesterday. There were over 2,000 participants. It's a 10-week learning community to accelerate telemedicine implementation for ambulatory care providers. And we welcome anyone interested in learning more about how to adapt to the current opportunities to implement telemedicine to join that. All the sessions are recorded and we'll share information about that as well. With that, Rick, I'll hand the mic back to you.
Thanks, Bruce. So we do crowdsourcing questions for each of the rounds, and we've learned a lot from the responses of participants and panelists and speakers with this. So this one is trying to figure out where you are with the challenges in your organization's response. So in the past week, what has been the most challenging for your organization's response to COVID-19? In the past week, what has been the most challenging for your organization's response to COVID-19? It also helps to see people frequently did this spontaneously, but it really does help to see where people are from when you put your responses in. So thanks for that, and please, be active in the chat on that. With that, I'm going to introduce our speaker. It's an honor and privilege to introduce my friend and colleague, Dr. Ed Michelson, Professor and Chair, Department of Emergency Medicine at the Paul L. Foster School of Medicine at the Texas Tech University Health Sciences Center, El Paso, Texas. Ed, welcome.
Thank you. Thank you very much. Thanks to you all for inviting me today. I appreciate it, Rick and Bruce. And let me start sharing my screen and make sure that everybody can see it. I think we've got it. Okay, well, it's a pleasure to join you all this morning. Today, in the short amount of time that I have, what I'd like to do is speak to you about how we have managed our patients here in El Paso during the COVID-19 pandemic. I'm sure there's many ways that hospitals have adapted to dealing with an influx of infected patients. And today I'm going to focus really on our patient flow and what we did to try to keep our non-infected patients safe as well as our staff safe during this process. By way of background, my practice is in El Paso, Texas. We are on the border with Mexico. We're dwarfed by our sister city, Juarez. El Paso has about an 800,000 population compared to about 2.3 million right across the border from us, which is literally 1 mile from my hospital. We saw, as many of you did, the chaos playing out on television, particularly in some of the East Coast and New York hospitals when they were hit with huge numbers of patients. And that all happened literally months before we started seeing an increase in cases. So that gave us pause as well as time to try to prepare to hopefully avoid those same scenes and not be on television. So the goals of my talk today are listed here. The way we decided to keep us safe was to identify possibly infected patients literally at the front door before triage. Once identified as having COVID or suspicious, to move them to an alternate location to complete their triage as well as their workup. We also will talk a little bit about our negative airflow rooms, the importance of keeping the rooms and those patients separate as much as possible and how we did that. Obviously, we enforce universal mask usage for staff and patients. And probably the most important thing we learned was the need to avoid boarding. So we set up a screener at our ED ambulatory entrance, and it's a common entrance for both pediatrics and adults. They were given standard questions to ask every patient presenting, including things like, have they been exposed to known patients who are COVID positive? I'll tell you, in El Paso, this is a huge deal. We've had multiple members from the same family present, usually different times, where the first one got infected, got sick, presented as a patient, and shortly thereafter, the husband or wife or other relatives in the same household also presented. I think we've had as many as 5 from the same household all show up at different times. We asked about respiratory symptoms, shortness of breath. Those patients who were positive for either of those questions were directed to a separate triage tent we call Tent A. I'll show you that in a minute. But the whole goal was to avoid cohorting possibly infected patients with our regular patients and keeping them out of the main waiting room. We also tried, to the extent possible, to keep these patients out of the ED completely during their care. So here's a picture of the little canopy that we set up in front of our entrance. And there's a screener station. There's a place for the nurse out here to register the patient, put their name in at least, and direct them to the right location. That operates 24/7. So pulling back a little, here's the view of that same screening station, and it's a short walk down this walkway to Tent A, which is our triage and screening tent. Behind that are 2 other tents that I'll get to in a few minutes. So once patients are transferred to Tent A, those include not only patients from our front entrance who answered one of the questions in the affirmative, but also some of the EMS patients who were stable were brought to the tent and not brought in the EMS entrance if EMS believed this patient might be COVID positive. The tent is staffed by a triage nurse as well as one of our APPs, plus or minus a medic to assist, depending on volume. And the process in the tent was to get a brief history, to obtain vital signs, pulse ox being incredibly important because hypoxemia was one of the main presenting symptoms for a lot of our COVID patients. We also were able to do the nasal swab and do in-house testing for COVID and blood work if indicated. Many of the patients who came to the tent may have had COVID, may have been early, but if they had good vitals, good mentation, and their pulse ox was acceptable, they were actually discharged from the tent without ever entering the department. We obviously gave them paperwork for follow-up, recommendations for who to see, when to return, what symptoms to watch for. But a number of the patients actually were discharged from the tent, having never entered the ED. So here's a picture of EMS actually bringing us a patient into tent A. These are really impressive tents. I would call them military grade. They're double walled. The big blue boxes here is an impressive HVAC system, including HEPA filters. And when the flap is closed, the tents can be negative in terms of negative airflow, so all air leaving goes through one of those filters. Now, we actually had 3 tents. So tent A, I just described to you for triage and workup, and discharge or admit decisions most of the time were made in tent A. Well, what happens when you get real busy? Each of these tents will hold about 10 patients comfortably, with some separators in between patient positions. We then moved to tent B, which is the same type tent behind tent A, and that was designated for patients who were confirmed COVID positive, but stable. Stable means that they didn't need to go on a cardiac monitor, they didn't need immediate resuscitation with fluids or pressors, and they did not need high flow oxygen. Some of the patients would go to tent B who were going to need to be admitted because they were going to need nasal cannula oxygen or other treatment. And this allowed us to prevent tent A from becoming overloaded. Also, patients who needed a longer workup, because some of our COVID patients actually presented with other problems. And those that were really going to need to be there for maybe a couple of hours, we would move to tent B and we would staff it appropriately for that workup. I have to tell you, most of the time we've been in operation, tent B has rarely been needed. But at times of surge, we moved to tent B as well. And finally, our third tent, tent C, is our clean tent. And that became the location of our alternate fast track so that we could see uninfected patients in the third tent who would need short workups and most likely be discharged. So all 3 tents have 10 curtained separations for patients. They each have a separate intake area. I mentioned the HVAC, but they also include ceiling lights, cots, chairs, and other equipment that we would need to take care of them. We also brought portable computers in. We set up a Wi-Fi access point so we had good coverage. And these were all for short stay patients. No one stayed in the tents overnight. And frankly, the tents have all shut down every night at midnight or thereabouts. So here's a view inside one of the tents. And again, you can see the triage nurse near the front waiting for the next patient to come in. The 3 tents were all located close to the ED and also close to our decon entrance. Our decon room became our portal to move patients from the tents into the ED. And actually, we use that room for things like portable x-rays, EKGs, stuff where you need some privacy and or you need equipment. The decon room was also the portal for staff to access. And let me show you a picture of the setup. So this is the back of tent A on the right. Tent B is the one right here. Tent C is just to the left. And here you can see the covered walkway into our decon room that allowed for the movement of patients. What I really need to emphasize is that all of these patients who were thought to be or confirmed infected moved through separate pathways compared to the non-infected patients. Now, part of the strategy also involved beefing up our number of negative airflow rooms. We worked with the hospital to create multiple new inpatient rooms that were converted to negative airflow so they could accommodate COVID patients safely and separately from the rest of our hospital population. All of our admitted patients, including non-COVID, received a COVID test first in the ED so we could confirm that we did not have an asymptomatic COVID patient with pancreatitis and inadvertently put them on the wrong floor. Our COVID patients in-house were cohorted to common floors and hallways. We also converted our 6-bed ED fast track to all negative rooms to create more capacity within the ED. And that is also our overflow site. Should we run out of COVID ICU beds, we would revert to that 6-bed area as an ICU. And the way this was accomplished was actually pretty low tech. Here's a picture of one of our rooms in the C-Pod, and you can see that the maintenance folks pulled out a window, put a board in with a box that they built, a fan blowing outward, and a filter. And as long as we keep the door to the room closed with the fan running, that room is now a negative airflow room. I'll tell you, this happened to about 30 or 40 rooms within the hospital, as well as our 6 ED rooms. So here's the layout of our department, very busy slide, but what I'll focus you on is the pink rooms here were our negative airflow rooms before COVID. I think we had about 5 of them. Clearly not enough during a pandemic. So what we did is, here's our decon entrance, and here's the walkway that leads to all of our tents. The C-Pod, we made all of these rooms negative. We also designated one hallway for COVID patients should we be overwhelmed with patients. And that made one hallway also our so-called dirty hallway. Patients coming in through triage over here on the right could be fed to clean rooms down the other hallway. So that gave us the ability to, again, cohort and kind of separate the possibly infected from the non-infected patients. So in summary, our plan for managing COVID patients in the ED was first to screen for positive or patients under investigation at the front door, to separate out those patients who screened positive to a separate triage, waiting and workup area. We also separated our workup area inside the ED to try to keep the COVID and non-COVID patients apart from each other. We added negative airflow rooms both in the hospital and in the emergency department through fairly simple modifications. And we increased our inpatient capacity so that we could avoid holding admissions in the ED, particularly avoid holding COVID admissions. And then finally, we mandated universal mask use by all of our patients and staff. So with that, let me stop, and I can take questions or hopefully answer any issues that folks want to bring up.
Ed, thanks for the presentation. The photos especially helpful. I mean, the tent description, but the photos were really helpful to me. I've got a couple questions, and I'm going to turn over to the panel for any of their questions or comments on your presentation. So I think back to the rounds we did back in March. And it's fascinating to hear your presentation as compared to, for example, what New York City was doing. And you mentioned, you were trying to take you didn't want to be in the same place. You wanted to learn from that. So, okay, so some of the same things from New York, some of the same, you replicated. Of all the things that you took from learning from previous surges, which one would you tell people that haven't gotten to the surge yet, but they're anticipating it? Which of the ones that you implemented you think is like, you got to do that one?
Yeah, great question. I think the screening at the front door and by EMS is really important. I think keeping, if at all possible, separating those patients who are infected or might be infected away from other patients is incredibly important. And another reason that's important is we experienced a tremendous drop in our total ED visits. That hasn't really been discussed very much across the country. But I would say when things were playing out in New York, when we were into April, we were down 40% on our total visits. We saw patients presenting with STEMIs who had been symptomatic for 2 days, and it was too late to help them, well, to revascularize them. Our number of stroke patients presenting outside of the window for TPA or removal of clot doubled because people were afraid to come to the hospital. And the more that we can do to reassure our community as well for the non-COVID infected patients that they can safely come to the hospital and that we're going to take care of them away from infected patients, I think is really also important for all of those other folks who were probably negatively affected because they didn't come.
Thanks, Ed. I have one other question, and it's a new topic, boarding, but no. In all seriousness, so obviously the decades we've dealt with boarding and if there was ever a moment that the boarding needed to be like just solved, it's now for any hospital. So in your institution, how did that get unlocked? Because I'm speculating, but it might have happened pretty quickly, but how did that get unlocked?
Yeah, boarding, I think boarding is the #1 problem affecting most emergency departments, and it shows up in all of our metrics. To the extent that this has been a priority of mine for the last 4 years that I've been here. From the first month here, we added boarding hours as one of our key metrics, and it's reported widely to hospital leadership, to the hospital board, as well as to my school leadership. So every month I have a report where we track in thousands of hours the amount of boarding of inpatients that we do. We track psychiatric patient boarding, which is a separate problem because keeping patients until a psych bed is available is a challenge, but it also affects our throughput. And I've hammered away every month pre-COVID on the effects of inpatient boarding on how that reduces our real capacity and therefore causes longer wait times, causes longer times for door to provider, causes an increase in elopement and left without being seen rates. So our hospital gets it because they've been hearing it from me nonstop. When it came to COVID, we reinforced that by saying we can't let COVID patients board in the ED who need admission for the exact same reasons. And the hospital really proactively stepped up, identified their need to create new beds, surge beds, and we held them to it. We had weekly, daily calls in the beginning where we tracked each day how many patients are we holding in the ED, how many COVID patients have not gotten upstairs. And my question was, why? Why are they still here? What is the status of those other beds? So I really think that the ER shouldn't take it alone. The hospital is very much a part of the success or failure of the ED as it relates to flow. And the hospital needs to be able to appropriately take care of inpatients outside of the ED.
Thanks, Ed. I know Sandy wants to make a comment on the boarding, and especially appreciate your comment about like, okay, so, you know, decades on, but and you've been dealing with it there for some years. What happened during COVID? Because it's critical right now. Sandy?
I think this is an issue whose time has come. We've been talking about boarding for a very long time, and we know all the bad things. Now it's critical because boarding a COVID patient in the emergency department, and there are plenty of places where that occurs, is just unthinkable. And the infection control issues. We've been talking, ASAP's been talking with the Joint Commission, ASAP's been talking with the CDC about the fact that infection control measures that are taken onto the floor and have been added for ambulatory care have to apply to the emergency department. And we cannot have patients waiting in the hallway in the emergency department who are COVID positive or potentially COVID positive because they're waiting for an isolation room in the hospital. And that's what we've seen with C. diff. That's what we've seen with everything else. And I think here, Ed clearly works at a hospital and has done his homework, as I expected him to get the hospital ready to do this. But so many of our hospitals are not ready for this and do not see that the ED needs infection control. And so I think we're going to need help from others to make that statement. And I think other federal agencies may need to get involved. Hint, hint.
Sandy, I totally agree. You know, we don't have hallway beds, period, end of sentence. When I came, I said no hallway beds. Patient care does not happen in hallways. It's not acceptable. If the inpatient units want to have hallway patients, then I'll have hallway patients, but the inpatient units don't want it. So pre-COVID, during COVID, we do not have hallway beds, and that's the new culture here and the expectation. I think for too long, it's been assumed that it's okay to let people back up in the hallways, in the closets, in bunk beds, in the ER. That was normal, that the ER was this vast repository holding patients that would be delivered to the floor when the floor was ready. And it's not acceptable. And it's much worse when you're dealing with patients with infections.
Thanks, Ed, and thanks, Sandy. Well, one other question or comment from any of the panelists, and there's a number of questions in the QA, and I'm going to try to pick out at least a few of them, and some of them are pretty rapid fire, like kind of yes, no kind of things. Any question or comment from any of you? Oh gosh, Carol, go.
Yeah, I just, a couple of things. I don't know if it's been an issue in your system, but certainly where I'm at, they're running out of the reagent to do the rapid COVID test. So we're actually treating every patient as if they are COVID positive. And I'm wondering, I know you have these separate rooms, but so many times the patient will come in for something else. And, example, you get a trauma patient and they don't have any cold symptoms, but you do a chest CT for a different reason, and boom, it looks like a COVID test, a COVID chest CT, and they turn out to be COVID positive. Have you had problems where, you've got somebody like that in your COVID-free area in the ED, and how do you manage that?
Right. So, of course, we've had our challenges with testing. In the beginning, we weren't able to test every admission, for instance, because we didn't have enough tests. And in the beginning, we didn't have rapid turnaround tests. So this is why universal mask use has been incredibly important. For all patients are required to wear masks. All providers have worn masks. And then for those patients who turn up unexpectedly positive, once we know that, we will move them to a negative room. We'll attempt to admit them to a negative room upstairs, and they'll get special cleaning of the room they were in. Fortunately, what I can tell you is we have only had 4 of our staff become infected with COVID, 2 of whom clearly were outside of work. They were social contacts. One of my interns was infected in the medical intensive care unit when she was taking care of 3 or 4 patients who were COVID positive, so there was probably a breach. And really only 1 in the ED that we know of, which was probably a breach. So yes, testing is difficult. When you don't have adequate testing, you can only test the suspected patients. But this is why we have to assume or be concerned that all patients might have COVID and be really careful with our mask use and hand washing.
Thanks, Ed. Paul, go.
I guess, thank you for the great presentation. My question is, you mentioned looking at what was happening ahead of you in the Northeast, and what did you use as a trigger to figure out when it was time to deploy the resources, and what was most compelling about what you saw in the experience? I mean, obviously the visuals you mentioned, but what else was the data that really pushed you in that direction? Because I think, those that have not yet experienced the wave obviously are going to learn so much from what you're presenting.
Yeah, thanks for the question. I hope so. Because really, I think we've all learned a lot from each other. I was telling our new interns who just started, what a strange time to start your residency training. But what I was telling them is I can't remember any time in my career when I've spent as much time reading about one disease for this period of time. I think we're all learning from each new article that gets published, from different venues like this one, as well as others where people share information professionally. And fortunately, our CEO knew, because we're the county hospital, we were probably going to get the lion's share of cases. He was proactive in getting the tents. Now, his idea of the tents, don't tell him I said this, was that this would become the inpatient COVID units, that he would put all the COVID patients in the tents and not have to put them in the hospital. Well, there's a little bit of a problem with that. First one being there's no running water, there's no plumbing, and people need to have running water and plumbing once in a while. There's also not piped in oxygen, and we know that COVID patients who get sick need a lot of oxygen. So I thanked him greatly for giving us tents. I didn't think I needed 3, but I wasn't going to say no. And we quickly repurposed them for a different use, for temporary rather than overnight use, and then refocused him on getting the inpatient side prepared to take more patients.
Ed, thanks. I've got a couple. There's a lot of questions, and I'm not going to be able to get to all of them. It's not like discriminatory. I'm not cherry picking questions. I'm just trying to cover some. Okay. So there are some tent themed questions. Was weather ever an impediment to using the tents? And will the tents hold up to summer storms, and what's the plan B if the tents go down, I guess?
Yep. Perfect timing for that question, because we're going to be over 100 degrees here in El Paso for the next week or so. They're very sturdy as far as wind and rain. And we did have some windy times in the spring, which we always do. No problem there at all. They have built-in floors. They're quite comfortable inside. The biggest challenge is temperature. It's the biggest challenge. The AC units that came with this do well up until the 90 degree or 95 degree range. And then they don't do so well once you get around 100. Matter of fact, that's my next project. I have my infrared thermometer. I was out there yesterday, and I have a plan to fix that. We have swamp coolers. People in Albuquerque will know what a swamp cooler is. But in addition to it being 105, the humidity is going to be about 10%. So they have these nice swamp coolers in front of all of the screening ports to the hospital. And one of them is going to get moved from that site to right next to the condenser coils of our AC unit. And I'm going to blow cool air into that AC unit to get another 10 degrees of cooling out of our tents. So that experiment is scheduled for this afternoon. Stay tuned. But you're right. Hot temperature is potentially a limiting factor on the tents.
So Ed, did like plant operations like hire you, or what's the deal? Anyway, so if there's another question about the tents. If EMS went to 10A, how did they communicate to the tent? I'm assuming
Right.
the radios they normally used were located in the main ED.
So what would happen would be that they would do their medical command through the normal radio channels into the main ED. And based on that discussion, we would simply direct them to show up at 10A and not come through the EMS entrance. And they were very comfortable with that. And our nurses assumed that if they had a patient come in by EMS, we told them to. So it wasn't a problem.
Another question, this is not tent related, but does your center coordinate with the healthcare facilities in Juarez, and the impact in cases and deaths your facility has treated on the Latino populations you serve? Are they disproportionate?
Yeah. Well, we're a very unique community in that we're over 80% Hispanic on the US side. We're also unique in that there's about 150,000 US citizens who have homes in El Paso. And there's a lot of movement back and forth across the border every day. Even though the border has been restricted, it's never restricted to US citizens returning. We only have partial information on what's going on in Juarez, but I know it's not good. They've publicly reported about 600 deaths. The problem in Juarez is that you can't get a free COVID test. And there's a lot of people working for $1 a day. They can't afford a COVID test. So there simply isn't much testing. So if you don't test many people, then you don't have many cases. We know that the hospitals in Juarez are overwhelmed. We have seen a number of people coming back to the US for care. We've also seen a number of US citizens who, by history, probably were infected in Juarez because of crowding and lack of social distancing. So it has definitely impacted us significantly. I also think that the El Paso County statistics in Texas are skewed because the numerator is pretty obvious. Numbers of people infected, number of people who pass away. But the denominator is probably bigger than just our population because it doesn't take into account the flow of patients coming across from the other side. We probably should look at a denominator instead of 800,000 of probably 1.5 million, or at least 1 million, to take into account those people coming from over the border, which would make all of our percentages drop.
Thanks, Ed. I want to do one more of these questions. There are a lot of questions in here that I'm not going to be able to get to because I definitely want to make sure we do the polling and then comments, questions before we close. So this one I haven't seen before, seen this theme before, but the question is, should a patient or patients who have been released from the hospital waiting on COVID results go back to the ER with mild symptoms of being possibly COVID? I'll read it again. Should a patient who has been released from the hospital waiting on COVID results go back to the ER with mild symptoms of probably being COVID? And it says should. What's your what's your ED doing? How about that?
This hasn't been too big of an issue for us. The bigger issue really has been relatives or household contacts of patients who've been sick. One thing that has been a problem, though, are nursing home patients, because the nursing homes do not want to take back a COVID positive patient until they test negative. We know that patients, because of high sensitivity PCR testing, they can continue to have a positive test for 30 days or longer, and they're not infectious to others by day 10 to 12. But we haven't been able to convince our nursing homes that they really should be able to take patients who need nursing home care before going home or returning to a nursing home until they test negative. This is a real problem, and this can cause a big backup. We did make arrangements with one facility in town that gets it, understands it, and will take our patients. But for those listening who maybe haven't hit the peak yet, something to think about, because we know that the older the patient is, the more likely they are to have comorbidities, to have a difficult course, and many of them may need post-acute care. So now would be a good time to try to set up some agreements and understandings with one or more of your post-acute facilities to facilitate taking them so they don't tie up an inpatient COVID bed for the next patient.
It was a great advertisement you just did for our rounds on Tuesday, where we're going to do acute care transition to long-term care with both acute care and long-term care in the same Hollywood Square. So that'll be, I mean, you know, it's rare that those communities talk together unless it's a phone call about transferring somebody. So it'll be a really good opportunity for people to learn from each other. Harry, you looked like you had a comment that you wanted to make. If you didn't, just defer, but and then I'm going to go to the polls, Echo.
No, I was reading through the chat. I just had a question about the physical layout and staffing, and I may have missed it because there was a lot of information in there, Ed. Are you separating staff from your COVID and non-COVID staff throughout an entire shift, or are those people moving back and forth caring for patients during a shift there?
Yeah, good question. The folks in the tent are pretty much there the whole day with a lunch break, at least a 4-hour to 8-hour period. In a 12-hour period, they definitely get a break. But one of the advantages of that is we're not burning through a lot of PPE, because our folks working in the tent will simply stay in their PPE the entire time, which really helps. If physicians need to go out to see 10 patients, they obviously will gown up for that, and they're wearing their N95s or respirator masks instead of their simple masks. But for the most part, at least in the tents, that's one way we've been able to preserve PPE, stay in it and work in it the entire time.
Thanks, Ed. Let's go around, or let's go to the polls if we could, Echo. And after, as they're putting that up, after the polls, I failed to have our panelists introduce themselves, so I'm going to do that. And then when you introduce yourself, any comments or question. So this one's like the simple, so this should not be like, there's no not applicables in here. And I would say over the past 2 weeks, the participation and rapidly getting responses has been really extraordinarily helpful, because it allows us to have more time for discussion, and a lot of people are participating. We're seeing about 50% participation. If you can move away from your second screen and do the polls, we'll get through these quickly. We got about 44% voted. And another 5 seconds. All right, let's stop there. Large EMS constituency, a lot of emergency nurses for sure. Great. All right, next. Okay, and by the way, this is a comparison, month-to-month comparison. Compared to last month, July's emergency department volume has increased, decreased. It's the same, don't know, or not applicable because you don't have anything to do with emergency departments. So for everyone's awareness, these responses are de-identified, so we can't pick out who like made this response to a specific question. And yes, like you're seeing these, HHS Healthcare Resilience Work Group sees these results as well. All right, 51% have voted. Let's see the results. 38% of you said it's increased compared to last month. Okay, interesting. All right, next. This is about trauma volume. Compared to last month, June 2020, our organization's July 2020 trauma volume has increased, decreased, stayed the same, or don't know, or not applicable. We're going to wait like about 5 more seconds. So, there's some very narrow, like, margins between a couple of them. Let's see how it plays. 53% of you voted. One time, well, a couple times I've said I'm betting on a specific answer, and then I got a chat response saying I'm not allowed to like bet on any of these. So, all right, let's stop there. 25% increased, 22% said the same, 8% decreased, and then there's don't know and not applicables. All right, let's do the next one. This is about blood product supply. Today, our organization has adequate blood product supply. Yes, no, don't know, not applicable. Easy, it should be pretty straightforward. So many of you have seen, like I've seen on the news, the media has reported, people need to donate blood and so forth. And I'm just trying to see if this is tracking with what I see in the news. 56% of you voted. Let's stop there. All right, 32% said yes, 13% no, and then the others don't know or not applicable. Thank you. Our organization has had discussions with K through 12 schools and or colleges regarding COVID-19. I'll give this like another 10 seconds and then we can stop. All right, let's stop there. 25% said yes, 31% said no. Thanks. Next. The handoff of patients from EMS to the emergency department in our region is working well, needs improvement, not working well, or don't know. And we've talked about that, the handoff previously in a few months ago. I'm saying a few months ago, but yeah, it's how long we've been doing this. And I just wanted to see where we are today. And when we finish the polling, there's one slide I think we'll be putting up, and then I'll go to the panelists, and I'm going to ask each of you to introduce yourselves, but then as you introduce yourself, if you have a question or final comment before we close, that'd be great, just to tee that up for y'all. Okay, 56% of voted. Okay, let's stop there. Wow, that's a lot. Working well, 37%. It's great to see that's the number one. And then needs improvement, 25%. That's a quarter of you. All right. Thank you. Next. Our organization has a wear mask policy. That's straightforward. Yes, no, or you don't know. Let's give it another 5 seconds here. All right, let's stop. 86% said yes, 7 no, and 7 don't know. Yeah, Sharon, write that one down. Yeah. All right, next. In our organization, the following consistently wear masks. So consistently. Staff, patients, visitors, none of the above, or don't know. And select all that apply, okay? So there's multiple choice. And I think there's one more after this. Oh, I see you can't, it only allows you to select one. I'm sorry, I apologize, but yeah, do what you can with this one. See what happens. All right, these are the responses. Realizing you only had the option of selecting one. Staff, 63%, patients, 3%, visitors, 14%, none of the above, and don't know. All right, thank you. Next. This is mental health topic. Over the past month, in general, the mental health of our organization's staff seems to be better, same, or worse. Over the past month, in general, the mental health of our organization staff seems to be better, same, or worse. %50 of you voted. I'm going to leave this one up here because I really would like to get as many of you to respond as you can. The mental health piece, it doesn't go away in our discussion on the rounds, and it shouldn't go away. And I want to make sure we stay on top of this. All right, let's stop there. 54% of you voted. 11% said better, 45% said the same, and 45% said worse. We have some work to do. And I want to say to the participants, speakers, and Ed, you all take care of yourselves. Next. This is the last one. I am aware of the National Academy's rapid expert consultation on staffing considerations for crisis standards of care for the COVID-19 pandemic, published July 28th. Yes, it was 2 days ago. I am aware of the National Academy's rapid expert consultation on staffing considerations for crisis standards of care for the COVID-19 pandemic, July 28th. Carol, thanks for letting us know you're jumping off. Yeah, it's important to get to a class at Harvard, so have fun. All right, 57% of you voted. Let's do a couple more. Great job. Let's stop there. 88 of you voted, 13% said you were aware, and 88% said you were not aware. Next, echo if there's a slide there. That National Academy's report, much like we have made sure people were aware of the AAMC's clinical guidance repository, want to make sure that you do have access to resources that others have pulled together. So this slide, pull out your iPhones, take a screenshot of it. But the National Academy's Rapid Expert Consultation on Staffing Consideration for Crisis Standards of Care for the Pandemic was just published a couple of days ago, and it was certainly in response to some of the staffing issues that we have all seen or heard of or experienced ourselves. So I would encourage you to take a look at that if you haven't already, much like I would for other guidance by other professional societies. Well, National Academy isn't a professional society, but other organizations, professional societies. I know ASAP, ENA certainly has a number of resources to be able to support each of you. So this one's there too. All right, next, well, you can leave that up for, yeah, thank you. That's exactly where I wanted to go. Thanks, Bruce, Amy, and Amanda, always. All right, so going back to the our panelists, if I'm going to ask a call on each of you and any final comments, but you got to introduce yourself first. Dan, I see you down there. All right, we'll pass. And Dave, please.
Yeah, hi, I'm Dave Thompson. I'm a clinical professor of emergency medicine at East Carolina University and medical director for Vidant East Care. The one thing I was wondering, Ed, about these window units that you've put in, has that wreaked havoc on your air conditioning, which is kind of important in a place like yours?
Yeah, a lot of people ask that question. No, it really has not. You don't need a whole lot of airflow to make a room negative as long as you keep the door closed. And with the door closed, the air coming into the room to replace what's going out is really coming like under the bottom of the door. So no, it has not been a problem at all. And it's a pretty inexpensive way to at least temporarily make the room safer for use.
Thanks, Paul.
So I would come back to the boarding question. I think, it's encouraging to see how much effort hospitals have put into eliminating boarding during COVID because of the pretty obvious safety concerns for patients and staff. But it shouldn't take more than the data that Dr. Schneider already referenced, that we know this existing safety concerns that boarding causes for our patients to really underscore why boarding is bad. And I think, we keep talking about all the things we want to take out of this pandemic. I think taking an elimination of boarding out of this pandemic would be yet another really, really important thing. The only thing I would say is, in addition to all the fantastic interventions that Dr. Michelson mentioned, one thing was really successful for us as an internal ED intervention was adding some runners inside the ED, so that when the treatment teams would go in and swoop on the patient when they first got into the room, that the runners would be able to take lab samples and send them up to the lab or bring new medications in. And basically it decreased the number of times any individual physician or nurse had to enter or leave a room as they started, especially sick patient care. So just a possible solution. Not everybody can staff that way, but to have a central pool of runners that allows the physician nurse not to leave so much in that first part of the patient encounter.
Thanks, Paul. Sandy.
I'm Sandy Schneider, Associate Executive Director for ASAP for Clinical Affairs, and also I work as an emergency doc in Fort Worth. Ed and I go back a very long time. I think your tent idea is amazing. That's perhaps the best tent setup I've seen. I do worry, you guys have 100-degree heat, that's bad. But if you think about the Northeast, where both of us kind of started off, it's going to be a limited application. And I'm wondering more about heating than I am cooling. And one other thing is, I was a little appalled at or not appalled, but distressed, I guess is a better word, at the wellness question. I do want to make remind people that we do have extensive resources on the ASAP website, particularly on the buddy system. But I think we need to do more in that area, Rick. I really do.
I'm right there with you. I keep bringing it up because I want to be able to support with these rounds however we can to make sure that we're all aware of not just the issue, but solutions that may help, and the ability to adapt quickly when solutions don't work and move on to something else that might. Harry.
I'm Harry Seibold. I'm an EM and EMS physician in Helena, Montana, past state EMS medical director, and sit on EMS and air medical committees for ASAP and NEMSB, and do consulting with the U.S. Forest Service. The last couple of weeks, I've made comments about this being a marathon rather than a sprint, talking about our own physical and mental health. But also, I think Ed's presentation brings into sharp focus that includes our planning for COVID. A lot of us have stood up multidisciplinary panels, have done many calls and meetings, getting systems set up. But as we realize things continue to change, and this continues to be a variable effort in our local communities, it's important not to let those systems that we've set up for planning kind of disintegrate and go by the wayside, but continue to keep those in place, because we're really at the start of things, and we need to continue to be nimble and be able to make clinical changes and changes in our physical plant and our staffing as things move forward. And I think Ed's presentation really brought that into focus.
Thanks very much, Harry. Yeah, it's the marathon piece. Ditto on that. Sharon.
Yeah, hi, Sharon Van Eerstel. Again, background is emergency department nursing. Ed, thank you so much for this great presentation. I so appreciate everything you've done with boarding and making that something that you've worked on in your facility. Would love to be able to hear strategies, things that we can try to push out, because that is a huge problem. You know, I'm hearing about it all over the place here in Georgia. So often the ED is a lot of that pressure is put on the ED. I was going to talk more about boarding, but I could not walk away from this webinar or this clinical rounds without noting that the masking question. You know, I would have hoped that 100% of organizations out there, the healthcare, the hospitals, would have a mask policy in place. And I think hopefully message out there to everybody, that is what we can do. I mean, we are the leaders in healthcare, and people are looking to us for this type of guidance. So we have to lead by example. If that is the expectation, like we really do need to be the ones that are pushing that. So hopefully we can ask that question again, maybe in a month, and we'll have 100%, but really masking, and we have to lead by example.
Thanks, Sharon. As you mentioned, the boring and the challenges of Georgia, and it obviously elsewhere as well. I mean, the question that just pops in is like immediately, how can it be in the worst disaster our country has seen in at least a century that we can't fix the boarding thing? I mean, wow. Anyway, Dr. Struminger, yeah, any comments, questions before we leave? I'm going to turn it over to Ed. Don't go away. Go, Bruce.
Just Ed, thank you for the inspiring presentation. Also, a reminder of the border health issues, and there were a few comments from colleagues in San Diego also raising the issue of the complexity of caring for patients when there's a border involved. And I think we maybe should, Rick, think of a session focusing just on border health and bring in colleagues from San Diego and other border towns. Because as you point out, your population is much larger than 800,000, and it spans a border, and it raises lots of complexities around equity as well as immediate needs.
Thanks, Bruce. Ed, any last words of wisdom for all of us.
Yeah, thanks. Well, first, thanks again to Echo, to you, Rick, for organizing this and for inviting me to present. I think during this pandemic, one of the things that has been the most important to me is our sense of community, of sharing, and of learning from each other. And because we're going through this at different time periods and different waves, I hope we can continue to do that, because I don't think it's ending anytime soon. So we want to learn from each of our best practices, share information and advice. And I would be happy to take questions from individuals after the event, speak with them if I could be of help. And I'd like to close, if I can, by just some good news. I'm going to share my screen and just share with you current data from Texas HHS. This shows the total patients in hospitals in Texas in black. The red line is ICU, and blue is available ICU beds. And this starts at just under 2,000, 1,700 patients back in June 1st. You can see how we ramped up and how busy things got until about 10 days, a week ago, 10 days ago. And now you can see we're coming down. So this is the good news. I think we've hopefully seen the worst of it here in Texas, and we're on the downward slope in terms of numbers of patients. And hopefully that trend will also continue around the rest of the country. So again, thanks for the opportunity. Thanks for everyone who's tuned in, who's interested in trying to make a difference and help our patients. And please reach out to me if I can be of any assistance.
Ed, thanks very much for actually, especially and on a high note. That's really great. And thanks very much for your presentation. Thanks to the participants, those who hung in there and like missed the first part of your 1 o'clock meeting. That's really cool. Yes, I've got to go to one now too. And let's see, our participants. Hey, great job on the polling. Really great job. I mean, that's a lot of information that we all got a chance to see and share, and provides us with a chance to focus on some things that maybe we weren't quite aware of, but put a little bit of a laser on those. And then for our panelists, always most appreciative. Echo, stellar, always, always, always. And hey, Ed, thanks so much. We'll see you on the next one. Bye.